Hello, my name is Geoffrey Colby, and I'm a neurosurgeon at UCLA. I'm also the director of cerebrovascular neurosurgery and the director of the neurosurgery residency training program. And it's my honor to speak to you today and participate as part of the LINNC series in China. And I'm talking about the evolution of flow diversion and my experience with Surpass Evolve. Here are my disclosures. I am a paid consultant for Stryker. I also do consulting work for a variety of other of the large companies in this space. The Surpass Evolve flow diverter system is FDA approved in the United States for treatment of large and giant aneurysms located from the petrous ICA up to the ICA terminus in vessels ranging from 2.5 to 5 millimeters in diameter. The international CE mark is a little less stringent and does not specify the location of the aneurysm or the particular vessel of the aneurysm. Stryker's flow diversion journey is quite extensive. It started in the mid-1990s with Dr. Wakalu performing a lot of groundbreaking research on how flow diverters work and the development of flow diverters. This led to the SCENT pivotal trial in the United States in 2012 and the acquisition of Surpass Medical by Stryker. Ultimately, the SCENT trial completed enrollment in 2016, which led to the FDA approval of Streamline system, which you all have in China in 2018. And now we've moved even beyond that. We're into the next generation, which is the Surpass Evolve, which was FDA approved in 2020 and should be available to all of you very soon, as far as I know. The Surpass Evolve flow diverter is a distinct flow diverter from Surpass Streamline, which is the first generation device. They're both made of cobalt chromium. Surpass Streamline, as you all are, I'm sure, aware, comes in several sizes. The most widely used sizes are either 72 wires or 96 wires. And this is different from the Surpass Evolve, which the most widely used devices are 64 wires. They do make a 48 wire device, which is 2.5 millimeters in diameter, but this is not available in the United States at this time. The difference between Surpass Evolve and Surpass Streamline, there's several differences, one of which is a higher braid angle. So it's 25 to 30% higher braid angle. The wires are thinner, but they do have the same number of platinum wires between the two different devices, Streamline and Evolve. And Stryker really aimed to simplify flow diversion by creating the Surpass Evolve. There's effortless delivery because there's low friction forces. The device can be dropped in a very predictable location. The device opens very well because of the 64 brand configuration and a couple other points I'll talk about in a minute. And the enhanced braid angle facilitates opening and facilitates radial force that leads to wall apposition. We have a Streamline on the left side of the screen. This is a device that you all should be familiar with. It's a over-the-wire system that involves two catheters. The Surpass Evolve flow diverter is an empty catheter delivery, and the Surpass Evolve comes loaded onto a delivery wire that is then pushed through an empty catheter to the intended target. And this is a mechanism that I think more people are familiar with. You can see Surpass Evolve on the top screen. The pedals that constrain the distal end are shorter than some other devices. This allows the device to open up nicely despite the presence of the pedals, and you don't need to push as much device out to get that distal end opened. The increased number of wires, so the transition up to the 64 wire braid, has facilitated opening of the device and also facilitates higher radial pressure, which helps with wall apposition. Here's a graph that shows the radial pressure of Surpass Evolve is 2.5 more times than Pipeline, and it's even more than Surpass Streamline, which itself has high radial pressure. Importantly, this device is also more twist resistant. This is one of the dreaded fears of doing a complex flow diversion case, is that the device will twist and not open up. And Surpass Evolve is more resistant to that because of the because of the braid angle and the 64 wires. It has a resheathing pad on the proximal end. This allows resheathing up to 3 times safely. In common practice, it can be done more than that, but the IFU states 3 times, and it works very nicely with very low friction forces. So my personal experience with Surpass Evolve, I've treated 36 aneurysms with this device. Most of these have been in the anterior circulation. Actually, there's an error on one of these slides that should read 34 aneurysms in the anterior circulation and 2 aneurysms in the posterior circulation. Most of the aneurysms have been in the clinoidal or ophthalmic segment, but I've also treated aneurysms off-label in the MCA and also in the ACA, as well as 2 aneurysms along the vertebral artery. I personally have had very good results with this device. As far as access goes, I've used radial access in 5 of the cases and femoral in the rest of them, and that is just my choice based on patient anatomy. All of the cases have been done using a triaxial support system, except for one case, which was a V2 vertebral aneurysm, and I just used a Cat5 through a radial sheath for that. I've used a single Surpass Evolve device in all of the cases, and all of the devices have been deployed in the intended location, and I have not had to switch to another device, for example, and I consider that a 100% technical success rate. And as far as follow-up goes, I've had 6-month follow-up in 79% of these aneurysms, and complete inclusion at 6 months on DSA in 20 of 26 aneurysms, or 77%. So I feel these are good results. So we're just going to switch to a bunch of cases here. I like showing case examples. We'll do a handful of these, and hopefully you'll get a feel for what this device can do and what it looks like during deployment. This is a 43-year-old woman with an irregular left superior hypophyseal aneurysm. You can see that there's some significant irregularity to this aneurysm. Here are some of the vessel size measurements ranging from about 3 millimeters to about 4.5. And I used a 4.5 by 12 size Surpass Evolve. This is an example of a couple of the working views showing the aneurysm with the black arrow. I put a couple of coils in this aneurysm. I did not jail an SL10 catheter in this aneurysm. I just went up, put a couple of coils in the aneurysm to occlude the most irregular portion, and then followed this up with the Surpass Evolve. Here's an example of some screenshots showing the Surpass Evolve being tracked into position. We can see the distal tip of the XT27 microcatheter. This is the distal end of the Surpass Evolve being tracked into position. Here's the opening of the distal end of the device. This can be done with either a simple small unsheath or a simple small push, depending on where you are in the anatomy. The delivery wire is pushed a little bit more. You can see the device opening up very robustly here. This is a lateral view with the oblique view on the left side of the screen. There's a gentle load of the XT27 catheter with the wire locked in place to further expand the device coming into the anterior genu here. The load is then reduced and the proximal end is unsheathed. And the wire is recaptured in a very low friction environment through the XT27. Here's the immediate post, showing contrast stasis in the aneurysm as expected on the oblique view on the left and the lateral view on the right. And here's the 6-month follow-up showing occlusion of the aneurysm. The patient did quite well. Here's another case example. So this is a small but irregular Pcom aneurysm. You can see the dimensions here. I am a fan of what I call the belt and suspenders technique, so providing some immediate protection with the coil or two, and then putting the flow diverter in place for the long-term cure. So you can see the tip of the SL10 in the aneurysm in the picture on the left, and then you can see the coils in the aneurysm in the picture on the right. The tip of the XT27 catheter is in place here for advancement of the Surpass Evolve. Here is unsheathing the first little bit of the Surpass Evolve in the MCA. Then dragging this back into position into the ICA. and a little more deployment of the device by, a little more expansion of the device by locking the wire down and providing a little gentle load of the XT27 catheter. Here you can see a contrast puff showing good wall apposition and good position of the device, not in the ICA terminus. And here's the lateral view, again showing good position and good initial wall apposition. The device was then fully deployed. You can see the immediate post showing wall apposition that was favorable. And the 6-month follow-up showing a completely occluded aneurysm. Here's another case. So this is an ophthalmic aneurysm with 2 bumps on it and a little bit more complex anatomy, but also in a young woman. In this case, so in some patients, particularly young women, and sometimes those with more tortuous or complex anatomy of the genu system, the vessels can be quite mobile, or they move a lot with the catheters in their various positions. And this was the case for this patient here. So I'm deploying the distal end of the Surpass Evolve. This is across the neck of the aneurysm, as you can see in the roadmap view on the left. But because of the mobile vessels, I made the decision to deploy the proximal end of the Surpass Evolve inside the Catalyst 5 catheter and then push it out from there. And this is a nice technique to do in either complex anatomy or vessels that are highly mobile. So here you can see the Surpass Evolve being essentially unsheathed into the Cat 5, and then the XT27 is pushed forward to push the back end of the device out of the Cat 5. And you can see the very nice deployment here using this technique. The wire is then recaptured in typical fashion, and the XT27 is removed. This is another case. So this is a 50-year-old woman with multiple aneurysms, one of which is seen on the screen here. She has fibromuscular dysplasia and dissections. She has this ophthalmic segment aneurysm. As far as the shape of this aneurysm, I thought it was appropriate for the web device, even though that is an off-label indication here in the United States. So I initially treated this aneurysm by placing a web in it. This is the lateral view. You can see the marker bands of the web device. This was the immediate post-deployment. We have nice contrast stasis in the aneurysm. It's a little bit of filling along the back of the aneurysm, but the thought was that that would probably thrombose over time because the patient was fully anticoagulated during the procedure. This is an oblique view showing the immediate post. Again, nice contrast stasis in the aneurysm as we would expect. But on follow-up, there was a small residual. You can see this almost pyramidal-shaped filling of the aneurysm. We see the DSA run in the middle showing that residual filling, and a reconstructed image on the right showing that residual pyramidal-shaped filling. Decided to watch and wait that, waited 6 months, an additional 6 months for a total of 12 months, and that filling was still present and a little bit more prominent. So my decision was to treat this by flow diversion. These are a couple screenshots showing the flow diverter coming across the web device here. You can see the top and bottom marker bands of the web device. Some additional deployment here coming around now the anterior genu of the cavernous carotid. A little bit more deployment, and then the final shot after the device was deployed. The Cat 5 tracked back into the proximal end of the Surpass Evolve, and the XT27 removed, showing good apposition, and you can see the Surpass Evolve in relation to the web device. Here's a native view showing good wall apposition. Now we're getting some nice contrast stasis in that residual filling along the back portion of the aneurysm. Here's the immediate DSA. And this patient has not had a 6-month follow-up yet, so I don't have that follow-up to show you. But I'm quite certain that this aneurysm will go away. Here's another example. So this is an ICA terminus aneurysm. This anatomy was very favorable for flow diversion, but the aneurysm, in my opinion, has some significant irregularity to it. So again, I decided to put a couple coils in this aneurysm and then treat by flow diversion. Here you can see the coil mass, and then the flow diverter was placed in the M1 back into the ICA with great vessel wall apposition. This patient does have a patent Pcom, so this flow diverter was done with the understanding that the ipsilateral A1 segment would fill across the Pcom, and that's exactly what we saw on our follow-up. We can see a right-sided carotid injection with excellent filling of the left A1, and then on the left carotid, we see a reconstructed vessel, an occluded aneurysm, and the expected small stump of an Pcom, expected small stump of an A1 because of the presence of the flow diverter. And this patient did very well. This is a more complex case. So this is a large distal A1 aneurysm. So this is an off-label case in the United States. You can see the anatomy here. This aneurysm had mass effect on the ipsilateral A2. So the proximal portion of the ipsilateral 2 was quite narrowed. And I will show you that in more detail. Here you can see the very short landing zone or potential landing zone in the ipsilateral A1, and then the narrowed ipsilateral A2 segment. So this is a case where, this landing zone is really too short to get stability of a flow diverting device. It's just going to want to pop into the aneurysm or herniate into the aneurysm. I decided to not place the flow diverter into the ipsilateral A2 segment because of this narrowing. I was worried about thrombosis. So I decided to cross the Pcom and put the distal device into the contralateral A2 segment. Here is the distal portion of the Surpass Evolve being deployed. I have an SL10 in the aneurysm, which will be used for coiling after the Surpass Evolve is deployed. So here is the distal end in the contralateral A2. Coming across the aneurysm itself. So this is, at this point, it's primarily an unsheath because push or forward load risks herniation into the aneurysm. So I continued to unsheath and the device opened up very nicely, as shown here. Here you can see the device. I then tracked the XT27 back through to recapture the delivery wire. And this was only done because it's a low friction system. If it was a high friction system, I would be worried about pushing on the Evolve device and herniating that into the aneurysm, but the recapture went very well. So here's the tip of the XT27 after the recapture, and we still see the SL10 in the aneurysm. I then placed an exchange length wire out the contralateral ACA, and I backed up the XT27 in case I needed it later or had to exchange for some other reason. I just wanted the catheter out of the middle of the device, given that the vessel was reasonably small. After this, put a handful of coils in the aneurysm. We were seeing improved flow in that ipsilateral A2 segment. And this patient did quite well from the procedure. You see some delayed flow in the ipsilateral A2, which was actually improved. On the 6-month follow-up. There was a small residual of the aneurysm on the 6-month follow-up. Her 12-month follow-up is pending, so we'll see how that goes, but I'm hopeful the aneurysm will be closed. This is another example. So a 73-year-old woman who has 2 aneurysms. There's one, basically ICA terminus or proximal M1, which can be seen here. And then there's another off the backside of the carotid at the anterior choroidal artery. You can see on the video, the proximal anatomy has some tortuosity to it. There's an extra bend in the neck, and then the cavernous carotid has some significant tortuosity as well. Here are the aneurysms. So this is the proximal M1 or near ICA terminus aneurysm, and this is the smaller anterior choroidal aneurysm. And my decision was to cover both of these by a flow diverter and drop a couple coils into the M1 aneurysm. So I did get robust access with an Infinity Plus and a Vecta 74. Here you can see the Infinity down proximal to that kink in the cervical ICA. And by bringing the Vecta 74 system up, higher up in the carotid, we were able to straighten out that kink and then advance the Infinity safely over that to get very robust support. Here we can see some of the working views. So we see the 2 aneurysms, the M1 aneurysm, and then you can see the anterocroidal aneurysm here, which is overlapped with the carotid. The XT27 was placed into the MCA. I had an SL10 catheter into the MCA aneurysm. Here's the initial deployment, and my plan was not to jail the SL10 catheter. I deployed a small amount of the Evolve flow diverter just to get to the point of the neck. I then placed a couple coils in the aneurysm quickly and continued the deployment. I did not want to jail the catheter in because I did not want to disrupt wall apposition of the flow diverter in the MCA and have to mess around with that later. So I put the coils in quickly. I then continued the deployment into the MCA, getting the device to bulge nicely as it came to the ICA terminus. And here the deployment continues. And then the device is finished off into the ICA across the anterior choroidal aneurysm. The delivery wire is recaptured. Here's the tip of the XT27, the tip of the Vectus 74, and the tip of the Infinity, all seen in view. And here are some post-implantation runs showing great vessel wall apposition. The first two images still have the XT27 inside the Surpass Evolve flow diverter. And the next images are with the catheters withdrawn some, showing excellent wall apposition, covering both aneurysms. This is the final run, showing all the vessels are nicely open. And this is the 6-month follow-up showing occlusion. I have one more case. This case I actually did yesterday. So this is a middle-aged woman with 2 ophthalmic segment aneurysms, basically one superior hypophyseal and one upward projecting ophthalmic segment aneurysm, as you can see here. And decision was made to place a Surpass Evolve flow diverter over both of these. These were the working views. So this patient had a hypoplastic ACA on the ipsilateral side, so there was no A1 segment or no large A1 segment. This vessel shown here is a fetal PCA, so we wanted to land the Surpass Evolve proximal to the origin of the fetal PCA. And here's the lateral view showing the double density where the fetal PCA is coming off. So this is the initial deployment of the Surpass Evolve, very nice opening of the distal end. This was a 4.0 by 17 millimeter device. So there was initial unsheath, followed by some gentle wire push, coming back around the anterior genu, and then locking the wire down and providing a little bit of gentle load of the device. This was a contrast puff to make sure we were at our intended distal landing zone. We can see the distal end of the Surpass Evolve is proximal to the fetal PCA, which is exactly what we wanted. Over here is the lateral view showing the same thing, and we're already starting to get contrast stasis. So once we knew we were in good position, we continued the deployment. This is the Surpass Evolve now being deployed across or back around the anterior genu into the horizontal cavernous segment. The wire was then recaptured. The Cat5 catheter was tracked into the proximal end of the Surpass Evolve, and then it was removed, and you can see the device open nicely. And this is the run immediately post-implantation. We're getting some contrast stasis, which is what we want. And here you can see the unsubtracted view showing excellent wall apposition. And I expect these aneurysms to go away over time. So in summary, so Surpass Evolve is the next generation Surpass flow diverter. And it's really designed for success in these flow diversion cases. It's a very low friction delivery system. The reliable opening of the distal end allows for spot landing. The re-sheathing is simple, again, because of the low friction in the delivery system. And the braid angle and the number of wires facilitates reliable opening and wall apposition in the device. And at least in my practice, it's been shown to be a powerful flow diverter. I've had excellent 6-month follow-up results with occlusion of aneurysms that I've treated. And with that, I'd like to say Thank you. This is a view from a sunset in Santa Monica in California, not too far away from UCLA. And if any of you have questions or comments or would like to share your thoughts, please feel free to reach out to me. This is my email here. It's gcolby@mednet.ucla.edu. It's been a great honor to speak with you today, and I hope the rest of your conference goes well.